Very good morning, everyone, and interesting session. Priya, thanks for inviting me. Now, I'll start off with a surge where you see that surge which happened just towards the end. Now, immediately at this point, it was a peculiar one because normally you won't see this, but can you see this? I've just gone back to show you how it happened. Now, just watch. This was just this little bit of a surge. And my Phaco handpiece, the tip is not even pointing down, it's actually pointing, just flat in the iris plane. But just watch, I'll pause this here. Can you appreciate this PCR here? It's a perfect PCR because there are no, it's like a rexis actually. So just watch how we manage this. So there was no vitreous disturbance, so I did not switch on the infusion and switch off the infusion and went from the side port, injected viscoelastic. Now since there is no vitreous disturbance and there is no broken edge, there are no loose flaps of the rexis. Now you can see that my lens actually delivered upside down. It always happens, when you have one complication, then other things will all, scheme up to make things life difficult for you. So anyway, I just tumbled it inside and I was able to put this lens in the bag because there was no vitreous disturbance and the break was self-containing, it wouldn't extend. So I'll be able to just focus it and show you how it looked at the end of surgery. You can see it now that this is the PCR. I call it as a perfect PC rent because it doesn't require you to actually manage it. But it will not always happen like this. Sometimes you will have problems, and just watch this video. Now, as I started this surgery, I paused it. Just watch, I was starting my bimanual IA. This is my aspiration port, this is the infusion port. And what happened is I should not have gone under the rexis here to try and aspirate this. In fact, I actually didn't even go under the rexis. I just switched on the aspiration. Just see what happens. Now, just see. I was just in that area trying to aspirate and I've caught the PC for some reason. Maybe it was a very shallow AC. So I have a break here which I have now seen that there is a break here. So I'm quickly trying to clean up the rest. My infusion remains on. I will now remove this cortex because I'm going to switch hands. And if I leave my infusion on, I will not disturb the vitreous. The trick is not to switch off the infusion. At this time, we normally panic and we do that. So now I'm switching off the infusion after I've put viscoelastic. Now I'll change my hands and I'll see if I can free this area of the cortex because I need to manage this break in the posterior capsule. So I just remove some of this cortex very carefully. And no high aspiration now because otherwise you'll end up causing fluctuations in the anterior chamber. And so you can see there I've managed to, even with the PC broken, I've managed to remove most of this cortex. The main thing is to be sure that there is no vitreous disturbance. Now I can actually go and tackle this small flap which I've created in the PC. Now you can see this flap here. I'm going with the micro. This is the flap, this is the break. So this flap here needs to be tackled. What I'm going to do is I'm going to try and make it into a primary posterior rexis kind of thing. So I catch hold of this flap and I see if I can complete it. Because if I don't complete it, then it will definitely extend when I put in the lens and it will cause a problem. So there I've been able to complete it into a small rexis and now I'm safe because now when I inject the lens, it is not going to disturb that area at all. Now as I said, whenever things add up, they always add up. Here you can see that I was doing a wound assisted injection. My cartridge tip got disengaged, the lens is stuck in the tunnel. So they always tend to inject more viscoelastic from the side, remove this, and then I inject it again. Of course, next time I don't make the mistake. And it goes in nicely second time, and I can position it in the back. So this was managed. Now, you'll not always be this lucky. My topic was more on triamcinolone assisted injection, but let's see what this one looks like. Now here, this was a posterior polar cataract, and I started with a routine cataract surgery. I tried to make a slightly larger rexis, at least a 5 mm or a little more than that. And you can see that I did the hydro procedure. I went with the chops. I was being very careful. I was not going to rotate the nucleus. I did only a hydro delineation. And I managed it as I would normally manage a posterior polar cataract, removing most of the chunks you can see there, and effectively leaving that last part there intact till the end. Now here I made the big mistake. I thought my nucleus is all gone. Just see what big mistake I've made. I would never normally do this. Maybe it was just being rash. And as you can see that because that last part, so many times that, the posterior polar chunk is actually attached to the rim of the PC over there, right in the center. So you should never attempt to remove this in a rash manner like this because once your nucleus is gone, sometimes you start thinking that, things are going to be straightforward. They usually are not. Now here I've disturbed the vitreous, and since there is a vitreous disturbance, I cannot attempt anything else at this time. I have to go in for a triamcinolone assisted vitrectomy. You can see some bubbles also came in, but I've managed to clear up all the vitreous there. Then I go inject viscoelastic. It's very important to free this area of any kind of vitreous completely before you proceed further. Now once the vitreous has been tackled in that area, you can go and do a regular irrigation aspiration, bimanual irrigation and aspiration. And once this is done, then you have to reassess how big the break is. You can see the size of the break now. Now this is the size of the break. I will not probably be able to convert this, and I'm thinking whether I should put a multi-piece lens in the sulcus, or I can think about putting a single piece lens in the bag if this does not increase. So let's see what I managed to do finally. Inject viscoelastic and see how it goes. And I think I will go and do a single piece lens injection into the bag, and I'm able to get away this time, and it remains nicely centered, and the lens does not extend. I will not recommend this to most surgeons because I was fairly confident I'll manage this, so I went ahead. But for some surgeon who may not be very comfortable with injecting lenses into the bag with an existing break, I would not recommend this to be done. I would still recommend go for a multi-piece lens in the sulcus. So take-home message is not what I showed you there towards the end. Now this was a patient, this will be my last case. It was referred to me by one colleague. She was operating for a cataract, and she suddenly experienced a vitreous loss, and she abandoned the surgery. She thought that she had removed the nucleus completely, but I was not 100% sure, and there was no way of seeing whether the bag was intact or broken, or the rexus was intact or broken. So we did a B scan. We found that the posterior segment was fine, and we knew that vitreous is present. So this is how we tackled this about 2 days after the previous surgery. So here I'm trying to assess whether there is any vitreous in the anterior chamber towards the end. I've injected triamcinolone, and you can see that the triamcinolone stains the vitreous beautifully, and you can then take out each strand. You can see there that you can meticulously remove every strand of the vitreous which is strained by the triamcinolone. Some of it will find its way behind as well, doesn't really damage. In fact, these eyes look beautifully quiet next day. And once that is done, I will now meticulously take out the cortex gently, and somewhere I was trying to assess the bag, and I thought that maybe we could salvage this bag. It's always good to be able to salvage the bag if you can. I believe that maintaining the integrity of the bag is good. Now here again, I've managed to create some of the bag, some remaining cortex there. I'm going to remove this. Then I experience more vitreous, so you can go back again and clear it up. So there is no reason why you cannot do that 2-3 times if you have to. Sometimes as the case proceeds, you will experience more vitreous, so you don't have to abandon it there. You can still clear it very nicely and then proceed further. And I managed to remove almost all the cortex. It was a very sticky one. Then I realized that the bag may actually be intact. So at this point, I go into the bag, inject viscoelastic to reform the bag and see if the rexus is intact, the posterior capsule is intact. I feel it is, so I'm going to try and put in a CTR. And I have secured the CTR with a 10-0 suture tied to one eyelet, so that in case the bag is broken somewhere where I have not assessed it and the CTR goes into the vitreous cavity, I will still be able to retrieve it. So I call this as the suture secured CTR or suture insured CTR. So this way you will not lose the CTR. Now I managed to put in the CTR. You can see the 10-0 suture hanging out. Now I enlarge the incision to a 2.6 from my 2.2 and go in and inject the lens into the bag. And here it may be wiser to actually inject it, not do wound assisted injection. And see, I've brought the cartridge tip into at the opening of the capsular rexus in the lens. It would have been wiser to use a single piece hydrophobic acrylic lens which opens more slowly, and it's much easier to open directly in the bag. Hydrophilic lenses can open with a jerk. Now I've put it in the bag. I realize that everything goes well, so I'm now going to trim this suture and remove it. It will no longer serve any purpose, and manage to complete this case comfortably. So next day, of course, one small little thing towards the end, I think I'll be able to show you. If you don't trim it too close to the junction of the eyelet, you'll still might see this small suture there. It's not going to harm the patient, but you can trim it very close to the eyelet. That was the message. I think Priya, I'll stop here because we are going to be out of time and have to rush to the other session. I had a few more videos, but we'll skip those. Thank you so much. I'll be